Joining me today for the photobiomodulation masterclass. Well, that's triple S, I'll fix that. Photobiomodulation is really just a term for light therapy, laser therapy, all types of therapy using light to change the body in some way, modulation. We're going to be talking about low-level laser and high-powered laser. There's lots of terms for these types of lasers, and basically they all mean the same thing, except high power is, of course, over 500 milliwatts and low is under 500 milliwatts, and they're different classes of laser. But all in all, they're photobiomodulation. I'll reference a thing called an LED cluster. That's a common tool used in photobiomodulation. I believe it's part of your equipment that you might be able to get from Asta as well. Today is brought to you by Asta and Foot Medics, and I'm conducting this for them. So my name is Emrys Goldsworthy. I'm just going to click through. Sorry if I'm a bit stuck. I'll come back to that one. My name is Emrys Goldsworthy. I've been looking after their shockwave courses as well. I've been working as a clinician for over 15 years. I've got a bunch of different methodologies that I teach for anything from electro-dry needling to nerve manipulation to joint correction work, to rehab. I've been working in the industry for a long time, also as an academic. I was a senior lecturer for many years at Endeavour College of Natural Health. I worked under the musculoskeletal therapy department, because I was the head of the department for Queensland. And my particular interest is in nerves. I focus particularly my treatments on nerves and nerve entrapments and nerve dysfunction. So you will see a bit of a bias towards nerves. There is a bit of a look at tissues and repair. So for example, with many of these conditions that we'll refer to, there might be the protocol to treat, say, a tendon or an enthesis, something like that. You know, so it's not always that I'm wanting to treat nerves, but that is my particular focus. Because without nerves, there is no pain. So that's the key, okay? That's my opinion, and I'm sticking to it. It's worked for me for many years. I changed from the traditional model of tissue type therapies to more focused on nerves alone. So you will see that in my presentation. Okay. Now, as we go along today, I will expect there to be questions. Okay. And feel free to chuck them in the chat, the text chat up on the top of the screen. You'll be able to put them in there. And as I go along, I'll stop and answer some of those questions as they come up. Okay. So as we get started, there's going to be a lot of theory to get through. Bear with me. It'll all make sense. Some of you may have seen this stuff before. I'll do my best to simplify it and explain it in a way that a 5-year-old will understand. It's not that easy sometimes with physics, but I will do my best. Lasers are complicated devices, very complicated devices, and most of that theory you don't use in practice behind what a laser, how a laser works and things like that. So I will focus on it, but I will focus particularly on what you're going to need to know. All right. So today we've got what is laser therapy, the history of laser therapy, what is a laser, underlying theory of laser and photobiomodulation, and all the different approaches for the upper body. We're going to focus on the upper body today. All right. So what is laser therapy? So basically it's a type of photobiomodulation. And I've mentioned before, there are two types of laser therapy, under 500 milliwatts and over. Over is high-powered laser. Basically, that's hot laser. And anything under is considered a cold laser. So that's how I differentiate it. The hot laser or the high-powered laser is at certain levels can be surgical. In this, with what we're doing, it's much lower. It's in the low wattage, and it's used therapeutically, not for tissue trauma or damage or to cut. This is a different laser as well for skin approaches when, although you can use it, I'm sure some of you may consider this, it's not my area, beauty, but the beauty lasers are a different kind of laser. Sometimes I believe they use low-level laser and the high-powered laser, but the approaches that I'm talking about are going to be for musculoskeletal problems, and their lasers are designed specifically for the skin and I guess wrinkles and things like that. That's not what I'm going to talk about. Generally, most photobiomodulation is low intensity light therapy, so low level laser. Most of the studies are done on low level laser. The earliest research started there and continued there. There is a lot of high powered lasers on the market now, and in no way am I saying that one is better over the other. I think the consideration right now is there's more evidence for low-level laser. There are studies that do say that high-powered works better though over low-level, but we just don't have a large body of research yet. So I can't say anything for certain. All I can say is maybe this or possibly this. So basically, what does it do? The light triggers biochemical change within the cell. I'm going to go through this in detail, and it can be compared to the process of photosynthesis in plants, where the photons are absorbed, cellular photoreceptors take it on and trigger a chemical change. So this is kind of a conversion of energy into some other type of energy. And a roundabout way, energy does increase when the laser is applied. It just doesn't really get explained that way. You don't say light comes in, it gets converted to ATP. It doesn't work like that. I will explain it so that it makes sense that a roundabout becomes more ATP. But there's a lot of steps to get there. And so it still works that the conversion of energy is maintained at the same level of energy after, just different type. All right. If I stop and start, it's partly because people are being admitted to the webinar. All right, so the history of light therapy, basically I wanted to keep this nice and simple. Light therapy, the first person to be really notable was Dr. Finson, won a Nobel Prize for his work with lupus using light therapy. In 1960, Professor Mayman built the first functional ruby red laser. And in 1967, Dr. Mester demonstrated the first use of laser in biostimulation. Initially, they thought that laser would cause cancer. So they tested this out on, I believe it was rats. And they found that actually, no, it didn't cause cancer. In fact, it increased growth of their hair. And that was the first time they realized actually it's more of a biostimulation than a tumor promoting. So lots of studies have been done. Over 400 phase 3 randomized double-blind placebo-controlled trials have been published for low-level laser, particularly, and possibly others in that group, but it's predominantly low-level laser, and about 4,000 laboratory studies. LLLT is low-level laser therapy, just so you're wondering, if you're wondering. Okay. So what is a laser? So laser, it stands for light amplification by stimulated emission of radiation. If you're wondering, that's what it is. So here is a laser beam in that image. So a laser is an unusual light source. Most light you'll see is sort of going everywhere, or not staying to one line. Lasers produce a very narrow beam of light. So a light bulb is not a laser, obviously. A flashlight is not a laser. These are non-coherent light. Coherent light is in one line, and it's all the waves in unison, basically. The waves of light, because light is the emission of photons in a wave form. Okay, photons in wave form can be different types of wavelength. Okay, different wavelengths have different colors. So the color or the wavelength determines the wavelength determines the color. So we'll go through that in a moment. So say infrared light is different to red light. They're different wavelengths. So when you have infrared, red, green, blue, all these different colors, basically that's what you have with a torch. Because when all the colors are together, it's this white light because it's combined. You have non-coherent waves going everywhere. They're not all in unison, okay? Because laser light stays focused, it does not spread out much like a flashlight would. Laser beams can travel very long distances because they're in sync and in unison. Some lasers can go further than others, like infrared. Because of the amount of energy that's in them, how long that wavelength is, determines really how long they can go. So the longer that wavelength, generally speaking, from my understanding, is the longer it can travel. When we talk about using infrared lasers in the body, those infrared lasers are the ones that get the deepest. Certain types of infrared lasers are very, very effective at treating pain, but other higher infrared light therapies don't do much for it. So it's very specific therapy, and there are very specific protocols that we have to talk about. All right, so this is what a wave is. This is a light travel. This is a photon traveling in a wave form. You see there's a peak and then a trough. So there's the high point and then the low point. That the distance between the peaks is called wavelength, okay? And the amount of peaks per unit time is frequency, okay? Or also known as hertz. Each wavelength has a different color. As you can see here, the bottom, we have purple or violet. No, they're a much higher much shorter wavelength. They're a higher energy state, and they are particularly damaging wavelengths for the cell. Then we get blue, yellow, red. Infrared is even more of a length of wider wavelength. So sunlight and the typical light from a light bulb is made up of light with many different wavelengths. Like I already said, our eyes see this mixture of wavelengths as white light. So a laser, you can see here, are beams of light, beams or waves of photons, all in unison or in phase, okay? And that's what you're using when you use a laser. This is what's coming out. Whereas when you use an LED probe, a cluster, this is what the light would look like. Obviously a lot more photons, okay? All right, so how does the light become emitted, right? So in your laser, this is all lasers pretty much, there's some ways that this works differently because they'll use gases instead, but that'll make sense if you do some more reading on this. So this is the flash tube. There's light emitted into the flash tube from an external source. This is a laser, it's what the electricity is doing. The flash tube fires and injects light into the ruby rod. So this is a ruby laser as an example. The light excites atoms in the ruby, okay? Inside the ruby. Hang on, make sure that your audio is off. Make sure everyone's off. Sorry, I just need to make sure everyone's muted. Okay. Remember, if you have any questions, put them in the chat on the top, and I will answer them briefly in a moment. Okay. So once this light's come in and excites all of these atoms, and they start to emit photons as part of this process. So that starts to scatter the light, and some of these photons run in a direction parallel to the ruby's axis. You can see here, going backwards and forwards in the correct axis. So they bounce back and forth off the mirrors. There's mirrors on either end. As they pass through the crystal, they stimulate emissions in other atoms. So they keep hitting each other and they accumulate photons. And those photons then are emitted as monochromatic single phase collimated light. So in other words, a laser. Okay. There's accumulation of light, otherwise known as photons, going around inside the tube, and they get directed all the way down here by a mirror. They all go in the correct direction and they get emitted. Okay. Now, if you haven't done a lot of physics, and I'm sure I've bastardized it a little bit, that process is quite confusing, because why are those atoms emitting light, right? Well, some of it is to do with the electron effect, so that how they're hitting electrons and things like that. But I won't go into that because that gets very in-depth and we're not focusing on it. All right, types of lasers, there's a bunch. They all emit different wavelengths, otherwise known as different colors. You see here, this carbon dioxide one is 10,000 far infrared. That's a very, very damaging laser, and it goes very far into the galaxy. I'm sure that's where they would use it. You've got a few other ones. 694 red laser, ruby laser. A lot of the lasers that you will use have just got gases in them. So it's the gases that the light is hitting the gas, and the gas then starts to emit the photons that then accumulate. So often when you read about your laser, it'll have possibly like helium or something like that. Neon. I think argon is another. Yeah, this says here too. All right, our noble gases are commonly used there. I'm sure you can understand why. Now, classifications of laser, this is really important. Like the first four at the top, basically you won't use these. These are just everyday lasers, okay? But then we get to this bottom area where it says class 3B. These are moderate power lasers. Basically, that's the low-level laser, okay? It's still a cold laser, and it's still within a band that you like, that's considered, like I said, low-level laser. So most studies are done with a 3B laser, most research papers. Class 4, that's the high-powered laser. Obviously, the hot laser, somewhat. And at much higher levels, a class 4 laser can be damaging. All right, so they're the different classes. And just be aware that there are different insurances for the class 3B use and the class 4, depending on your insurer. So some insurance companies require a different certificate for a class 4 and a class 3, and sometimes it's different costs. Okay, depends on the insurance company. So the factors to consider when using a laser are the class of laser, so the wattage, the wavelength, okay? Different wavelengths have different effects. For example, red light has a particular effect on repair, improving repair, whereas near infrared and infrared is particularly useful for pain, although near infrared has a certain level of use for repair as well. The frequency, okay, so a lot of your devices will have hertz on it. So the light, so most of the time, 150 hertz is, anything over 150 hertz is used for pain. Lower hertz, like 30, 10, 50, they're useful for repair. Time per application, so that matters as well. All of these factors lead to different outcomes. So if you put a lot of time on a point with a laser, you're basically inhibiting, you're trying to turn off that cell. If you keep it on there for less time, so like 30 seconds or a little bit less than that possibly, probably find that that cell is going to more repair or improving the amount of ATP activity, mitochondrial. Got a few people coming in now, so just give me a moment. Here's some terms you're going to hear if you do a lot of reading on laser. There's a thing called a chromophore. Basically, a chromophore is a molecule that absorbs light. You know, it's generally considered something that shows a color, but it actually absorbs light. So, for example, when you are applying photobiomodulation to an area of the body, hemoglobin will absorb it. There is a type of laser called blood laser, where you emit light therapies over, you put light therapies over arteries, or you use a special applicator that basically opens up the artery, like through a needle, and then at the end is an LED or some other light source. And that light is then shone into the blood directly, and hemoglobin takes on that light and then carries it through the body. And the theory behind that basically is that where a cell requires energy, it will be absorbed from the hemoglobin. Lower energy states take on energy, such as ATP or other forms, when they're low. It's all relative. If an area has lower energy and this object, like a hemoglobin, has high energy, it will want to take on that energy. The particular interest is actually cytochrome C oxidase. Cytochrome C oxidase is a part of the inner mitochondrial membrane. It's a key component in the process where hydrogen ions are flowing backwards and forwards over this region in order to produce ATP. This is also known as oxidative phosphorylation. So it's the main way that we produce ATP. And that's how the main way that mitochondria produce ATP, energy. And so cytochrome C oxidase is going to be like the word of importance when we get to energy and the effects of what biostimulation really means. It's a term called optical window. So basically that means in a tissue describes a range of wavelengths where the penetration of that light into the tissue is maximized by it being red or near infrared or infrared wavelengths. So they've found that because of this, there is an optimal range and it's around 8-10 nanometers. In other words, it's near infrared. This is a sort of an area that's controversial because some studies are saying infrared is better, but some it's still near infrared. So for now, let's say that near infrared is the best to kind of have an effect on not only biostimulation, but also reduction of pain. So before we get into this, I'll just see if there's any questions. Any questions, put them in the chat. I'll answer them now. Anything? I'll have a look. This is your moment. This is your moment. Just admit a few people while we're on this. Okay, we'll keep going. So in this image, you can see red light and near infrared light or infrared light being emitted. Now you have two effects according to this study done by Domp. So the application of red light is absorbed by the enzyme cytochrome C oxidase, like I mentioned, and cytochrome C oxidase is within the mitochondria. The main thing that occurs is that nitric oxide, which is a type of reactive nitrogen species, in other words, it's like a reactive, like an oxidative stressor, but not quite, but nitrogen species. And it can basically block the passage of hydrogen ions. Therefore, it reduces the amount of ATP synthesis. So when nitric oxide is bound to the inner mitochondrial membrane through cytochrome C oxidase, particularly, it actually blocks the production of ATP. And you can get an accumulation of hydrogen leading to a leaking of hydrogen, leading to acidity in the local tissues. That's another concept. We won't go there. But the main thing is that when the light hits the cytochrome C oxidase, it bumps and kicks out the nitric oxide outside, even outside the whole cell, not just outside the mitochondria. Okay. So this is a really interesting thing. So the nitric oxide is a blood flow enhancer. So when it gets kicked out of the mitochondria, it goes outside the cell and starts activating blood flow improvements such as vasodilation and increased blood permeability into the well, not blood permeability, but just permeability so that certain immune cells can get through. When you have an immune response to an area, you have increased permeability of the arteries and you have vasodilation. The permeability increases. That allows the immune cells to get through. So nitric oxide allows for that when it gets displaced, but also when it gets displaced, the ATP levels start to go up. So we have an increase in energy. So that's the conversion of light into energy. It goes through that process. When you have an infrared light, it goes in and it actually activates the release of calcium. So you also get from that this thing called a secondary messenger system. Calcium activates the secondary messenger system, calcium-mediated secondary messenger system. And this system basically activates genes. It activates a bunch of different other processes that leads to more reactive oxygen species. This is not such a bad thing. Reactive oxygen species going up helps with repair. It also helps with infection. So there's often the use of lasers where cells are infected, ROS go up, and it eliminates the pathogen. It's part of that process. The CAMP, cyclic adenosine monophosphate, it is part of it's another secondary messenger system component, can activate genes. So basically, if you want to produce more channels for a certain purpose, it might be more light sensitive ion channels for calcium, it might be other types of channels, it does that. Part of the key to understanding this, right, is that when you activate the intracellular mechanisms such as calcium, you can excite a cell doing that. The whole cell becomes excited. You can, as part of that, have another effect, which we'll need to talk about, because the near-infrared light also has an effect on the transmission, which is really key. Talk about that in a moment. So laser at low doses has been shown to enhance cell proliferation, basically making more cells, okay? Healing effects, this is what that means, reparative effects. Fibroblasts, they're multi-use, of course, and that also includes chondrocytes for cartilage, okay? No. Osteocytes for bone. Also osteocytes, also keratinocytes, endothelial cells, lymphocytes, in other words, all tissue type. These cells basically create the substance needed to repair, okay? So that's all you need to understand, is that these cell types basically give you more of whatever said cell might be, bone, ligament, a collagen-based substance like connective tissue, that kind of thing. Mechanism of proliferation is thought to result from the photostimulation, the light stimulation of the mitochondria, leading to activation of the pathways that are signaling the transcription of the genes and eventually giving rise to the growth factors. There is not a clear understanding of each individual step, but we see that we've got the gaps in the process, but we understand the key processes. Laser can enhance neovascularization and angiogenesis. Basically, this means more blood vessels, increases collagen synthesis. It's exactly what you want to do when you're dealing with wounds or any kind of acute injury or chronic non-healing injury. Okay. It also includes osteoarthritis, degenerative processes. So there's this term biphasic response. I'm actually, for time reasons, not going to go into this so in depth, but basically you've got two phases, right? You've got a stimulation phase. That's that to do with the light dosage. So when at a low dose, it tends to have a stimulatory effect. At a high dose, it becomes inhibitory. Now you want the inhibitory effect for something that you want to create analgesia for, so pain relief over a nerve that's causing irritation and pain for that person. you're going to use a stimulatory response curve, which is the lower dose, the lower amount of time using the laser, lower frequency. That one's going to be used for, say, a wound, or say something you want to repair. You know, you might have someone who has tendinopathy. Generally speaking, tendinopathies respond better to lower dose. The nerves that go to the tendon, though, would be better to deal with them with higher dose. So those nerves coming to the tendon, we want to reduce the pain from those nerves. We can laser those nerves that go to that tendon, okay, but not on the tendon necessarily. Well, then you would use the lower dose for that. We'll talk about that more as we go along, okay. So the neural blockade is the mechanism of which infrared light and near-infrared light at a higher dose, 1 to 2 minutes, is going to create basically an analgesic effect. ATP as the source of energy in the cells is going to be locked within the mitochondria. It's going to be released. When you apply the light, you can actually get this really cool effect where the internal cytoskeleton of the nerve becomes collapsed. So it disrupts the effect of movement of ATP or mitochondria throughout the cell. And also there's belief that it actually is also going to affect the emission of nerve signaling to the brain. So it blocks that as well because of the structural elements being collapsed within that nerve cell, that neuron. That's a wall, a blocking wall for signaling, okay? But they know it's the case, and it happens over a couple of days. There's an effect there for a couple of days, and I think it's between 30 and 40% reduction in nerve signaling. Basically, it's like using an anesthetic at a lower dose. It comes back to normal within a day or two, but that could be enough time to basically stop the pain cycle. Most laser treatments require many sessions. I will keep going because I want to get on to the cases. I'll go back if we need to talk more about that, but you'll all get these PowerPoints to read through. So the main difference between high-powered and low-level laser is that the powerful beams, over 500 milliwatts, are irradiated to penetrate deeper. So that's the whole reason why you would use a high-powered laser more so, to bring a desired higher amount of multidirectional energy in deep tissues. That's if you multi-directional, that's if you use a cluster with a higher powered laser. You do get a bit of that actually when you go inside the tissue. The light comes out and it scatters. As soon as the light goes into the tissue, human tissue, it tends to go out and it scatters out like that. So it does have a multi-directional effect because you're going to get colliding of the light with cells, and that then sends off other photons elsewhere. Okay, there's a lot going on within this, the superficial and deep tissues once the laser goes in. So people think that if I point a laser there, it just goes there, but it actually goes in and around that area. The exact distance around is really determined by how much watts there are and how what the wavelength is. So near infrared and infrared are going to have a wider distribution. All right, let me answer some questions. So what is the difference between infrared and laser? Explain about near infrared. Okay, so the different types of we've got red, near infrared, and infrared. Red is in the 600 band of wavelength. So that's basically the measurement of the wavelength is about 600 nanometers, and that's red. Then near infrared is in the 800s, and then over 900 is infrared. So near infrared 800, over 900 infrared. And infrared, the higher you go, the deeper it goes. So the longer the wavelength, the deeper it penetrates into the tissue. So the near infrared has a good penetration and has still got biostimulation effects and analgesic effects. That's why it's considered optimal window. Okay. Yeah, can I give an example when high powered is better than low level laser. All right. With high powered laser, you don't hold it on one point. You move it. It's like it's scanning. You basically will travel a course and go back and over again. If you hold on one point for too long, it heats the tissue up and all that light is getting converted to heat. If the light gets converted to heat, heat is not energy conversion to ATP synthesis in the cell. So if it gets converted to heat, that's where it's going. It's not, so the light goes in, it either gets converted to heat or another type of energy or ATP. You want it to go to ATP. When you start using high-powered lasers, it's likely that the best benefit is with pain, because overstimulation, in a positive sense, is really how you treat pain. You want to inhibit, all right? And to do that, you need high dose. When you use a high-powered laser, the dose is much, much higher. So it's going to cause that effect no matter what. Okay. Whereas with you use a low-level laser, and on the Aster laser that Aster sells the laser, it says Aster on the front. I think that it's Polaris. This laser can be on a low-level setting. Okay, it doesn't have to be high-powered. It can also be low-level setting, and that low-level setting is what you would use for biostimulation. In other words, for repair processes. Okay. I hope that helps. Side effects, well, it's to do with burning, right? So with any laser therapy, that's something that I do need to cover. I will mention this now. Lasers cannot be placed over the eyes, okay? You need to wear your special laser goggles, okay? Please note this. I will amend the slides to include that. I was focusing particularly on clinical application today, but let's talk about this. Everyone that buys a laser will get the user manual that will show you must wear your specialized protective goggles. You can't place the light over the eye. You can use LEDs over the eyes for particular conditions. We'll cover that another day. LEDs are fine. Whereas lasers are not, you can cause retinal damage. Can't place the lasers over an abdomen where a fetus is growing. So a pregnant woman wouldn't be going near the abdomen, okay? You can place it elsewhere like glutes, back, so that kind of thing, but not over the abdomen. Same goes for shockwave. So I think it's pretty obvious, but I will state it just in case. Lasers are used on the brain, but the high-powered lasers I've said in this slides not to be used on the head, but everywhere else. Whereas low-level laser is used on the brain. There are many, many studies done on transcranial LED or laser therapy. Okay. Other things that you might be more concerned with is an area of irritation of the skin, where the high-powered laser makes it further irritated. There might be others, and I will add that as a note in the PowerPoint. Make sure that that is included so that there is full clarity. I hope that answers it. But main thing is the main side effect of high-powered laser is due to misuse, and that is burns. Okay, I think that's pretty obvious. When you hold a high-powered laser over a point and it starts to heat up, I wonder what's going to happen next. Yeah. But with the low-level laser, there's almost no side effects. Same goes for that, no abdominal treatment with a pregnant woman. They say not to use lasers over cancer. Most of that is because we don't know what it will do, but there is next to no evidence that low-level laser at least doesn't have any negative effects or positive effects for tumor growth. It doesn't affect it at all. Some say to not use it over glands. In fact, I don't really agree with that. I think the evidence is contrary. Studies have shown that use of laser therapy, LED particularly, actually, over the thyroid can resolve Hashimoto's thyroiditis by itself. So I don't think that laser therapy, LED therapy should be excluded from use over glands if you know what you're doing. If you don't know what you're doing and you don't know why you're doing it, don't do it, okay? LED therapy is what I use over glands. There's a protocol for using it over the adrenals. There's a protocol for using it over the thyroid, okay? We'll see if we can cover that in the final session, the third of the three. All right, let's go on. So under 150 Hertz at around 30 seconds for tissue repair, this is what you use. Over 150 Hertz, 1 to 2 minutes for analgesia. Okay. So shoulder pain. Now you're going to see, and this is going to get a bit complicated because I treat nerves. I'm not going to talk about trigger points. I don't believe in them. That's just the fact. I don't believe in trigger points. I don't believe they exist. I think that everything that you are seeing with a trigger point is a nerve entrapment, okay? In a muscle, in fascia, whatever it is. I can explain why I think that, but the evidence for trigger points for me is very much lacking, and I don't believe that the treatment of them is very effective anyway. So I would say move your therapy to nerve entrapments and you'll get a better result. Putting it out there, you don't have to take it on. This is what we're going to do. So we're going to particularly focus on pain, all right? Shoulder pain. Doesn't matter what it is, it's about the pain, right? They might come in with a supraspinatus tendinopathy. I don't care. I'm still going to treat what their pain is, okay? The pathoanatomical approach is extremely dated. I would really get your head around not treating disease states of tendons alone. Don't just go in and treat the tendon and leave it. Think about where the pain comes from. You don't know that the tendon itself causes the pain. Often it doesn't. In fact, most of the time it doesn't at all. And so many people have tendinopathies and don't know about it. Most of the pain that you'll actually see is actually from a nerve. Even if it aches, you don't need pins and needles or numbness for it to be nerve. That's not how the mechanism is. That's only when you have a disruption of nerve transmission. The mechanism of nerve pain is the loss of oxygen to the nerve through the restriction of blood flow around the nerve. It's not because the nerve is being compressed completely. You don't need to have loss of transmission for it to be neurogenic pain. Okay, let's get on it. So in your pictures here, you can see lots of different points. This is the superior area on the left of the shoulder, and on the right, it's the anterior. This is the supraclavicular nerve, and if you have an anatomy, like Complete Anatomy app on your computer, you'll be able to find these nerves. Now, the palpation of this is very difficult because this nerve is very, very thin. But I would say that you'll find a patient will say, I have pain in one of these locations. Now, some of the points are up into the sort of trap area, so that wouldn't really be considered shoulder pain. But consider all these points as you go along. Now, the laser would be applied to the X's here. Don't worry about the different colors in this one. That's just so you can see it clearer. So I've seen here on the right, we've got superior area of the deltoid on the anterior and middle deltoid, and along that clavicle area and acromion. The suprascapular nerve, this is a very important nerve for shoulder pain, particularly posterior shoulder pain and deep shoulder pain. You've got points here in the superior aspect. This area is an entrapment site. So you find your spinal scapula and you just drop off looking for a sore point that is deep in that supraspinous fossa. Underneath that acromion and that spinal scapula, you should find another tender point, if this is the case for this one. And I would try to get it either on the bone or just below. This suprascapular nerve is innervating the supraspinatus and infraspinatus, and often they present as tightness due to nerve irritation. Muscles tend to get tight when they're weak as well, which is kind of all the same problem. Once you get the nerve functioning better, the strength in that muscle should increase. If it's inherently weak because it's not being used, because that person hasn't used their arm for ages, it's a lot harder to deal with that problem because the muscle will keep getting tight in order to protect partly, but also to improve its contractibility so that they can function better in the shoulder. These points are incredibly important if you can get on them. Go by palpation. thumb pressure. The musculocutaneous nerve. Now, this is going to be a really common one because anterior shoulder pain, this is the anterior aspect of the shoulder, anterior shoulder pain is really the most common, I would say. Right at the front of the shoulder here. And if you find on your front of your shoulder, your coronoid process, right? Mine sitting here, right? There. And then you just go just below and just lateral, you should feel this tender point below the coronoid process. Coracoid process, not coronoid. Coracoid process. And that point there is our first point of interest. It's our musculocutaneous nerve. And as you go down a bit further, you should be able to find it just before it hits the bone, just underneath the biceps. Even further down, you'll find one just under the belly of the biceps, right in the center. Hopefully you can see my arm there, right there. Ow. Now you're probably going to think that's biceps, right? But if I move that biceps out of the way and I push underneath it, there's that pain again. Oh, it's brachialis. No, it's musculocutaneous nerve. Muscles don't inherently hurt to touch. You might think they do, but I would say you're pushing on a nerve. There's no doubt about it. Like, nerves are everywhere and nerve entrapments are everywhere. So most of them are subclinical, meaning they don't have symptoms. They only hurt when you touch them. Okay, musculocutaneous nerve. I'll open up this to questions. So we've done a little bit. I'm rushing a little bit because of time, but I want to make sure that we understand this one in particular. Applying the laser here at over 150 hertz for 1 to 2 minutes, each of these points or anywhere along these lines is where you would apply it. Now, when it comes to something like high-level laser, high-powered, you would draw a line between the first point of tenderness and the last point of tenderness, and you would keep scanning that light at about that height above the skin. And you would scan from that point to the other point like this for the time. Normally you'll set the clock at 2.5 minutes. So you do that for 2.5 minutes to suppress the pain cycle. So the radial nerve, this is looking at it from the back of the shoulder. Now, the key to understanding how to treat the shoulder, right, is to understand that shoulder pain, no matter what the diagnosis, you approach it from the nerves. This is really the best approach to reducing pain, okay? So for posterior shoulder pain, you've got to look at radial nerve, okay? And here we have the triangular space at the back of the deltoid. Now that's going to be the key point of pain. I have also shown you down the arm a little bit. So that's where it hits the sulcus, the spiral sulcus, in the back of the humerus. Now those points are midway. So that's midway down on the right-hand side there. On the back of the left side, on the left side, you have the posterior aspect. You know, finding these points takes a lot of skill, and I've taught many clinicians over the years how to find them. It's very difficult over a webinar, but I can do my best, and that's why these images are here. And you can go to your anatomy texts or applications to look at where these nerves are, but I've given you a reference here. This is where you point the laser, okay? This is the axillary nerve. Now, the axillary nerve is particularly useful for any type of shoulder pain because it really does go around the whole shoulder. The skin of the shoulder, people will often say it burns on the side of my shoulder. It hurts here. It could be at the back, could be at the front, could be at the side. Often it's the side, to be honest. And there's this classic symptom of the pain goes along the line of that deltoid from the back down to its attachment. This is generally the axillary nerve in my experience. And treatment of any point of tenderness along that skin and in that muscle area with the laser is indicated. But I've given you the most likely points. The one on the right is the deeper component, right? And this area where it starts is called the quadrangular space because it's got 4 sides. This is quite high up in the back of the shoulder. And if you can laser there, you'll find that it's underneath the deltoid. You have to get right under. You can see in the image on the left, it's curled around that deltoid. That was the superficial part of that nerve. This is the deeper part. And you really need to get onto the tender deep points to get the best effect. It's my experience with the auxiliary nerve. The auxiliary nerve is particularly problematic with shoulder pain, and often you'll get more than one nerve. The classic symptom is radial nerve with auxiliary nerve with musculocutaneous nerve. They're the three I would say most common for shoulder pain. Okay, with headaches, I focus on these 4 nerves. Now, I don't use high-powered lasers generally. I mean, if you're going to use a high-powered laser in the head, I would put it down to lower settings. I don't know how much studies have been done on that cranium with the hotter laser, high-powered laser. So I would, knowing how many studies have been done with low-level laser, 500 milliwatts, I would go there. Okay, 150 or higher. I often use really high hertz, like 2 to 5 kilohertz, and probably about a minute per point. Sometimes I'll do 2 minutes. Now, remember, these points on the left side here are trigeminal supraorbital nerve points. This is that classic headache at the front of the head, all right? Those 2 points there on the back, underneath the eyebrow are areas where the nerve comes through the bone. So this is an area of impingement, and you need to make sure that when you're applying it, they've got their glasses on, make sure that's okay. If you can't, then you have to point the laser upwards. Okay, you've got to make sure the laser is pointed away from the eye. On the right here, we're looking at the auricular temporal nerve. This is actually the most likely area to treat for the trigeminal headache. It is situated over the sort of anterior aspect of the ear. You're going to find the nerve running through here and all the way up. And there'll be points here, somewhere in the middle of the temporalis, but also up and behind. So finding the tender points there are the key to dealing with that temporal headache. Okay, occipital headache. These are sort of the most common points. You have 3 different nerves running here. You have the more medial third nerve, the second one from the medial aspect, which is that long upwards nerve, the greater occipital nerve, and then the lesser occipital nerve. This lesser occipital nerve is the lateral one, and it just sits behind the mastoid process about here. And as you go back, you'll feel the soft tissues accumulate there, just like trapezius and other erectors. And that's about the area of where you're going to feel the greater, and all the way into the medial area, that's where the third nerve is. This is where I'd apply the laser over those tender points. Go by the patient and what they feel at the time. If they feel sore at those points, that's where you apply it, okay? In prone, the question was in prone, do I do this in prone? In prone, seated, whatever's easiest. Obviously hair is a factor. For me, it's not. It's a lot easier to treat these nerves on me. You've got to move the hair out of the way as much as you can. You pull the hair apart, get it out of the hair. You're going to get the hair's going to get in the way. Sometimes that means you've got to apply a higher amount of time to get enough energy in to suppress the nerve. Yeah, so that's often the case, particularly with long hair. But prone is easiest, definitely. Elbow pain. All right. Now, like I said, when it comes to, say, the high-powered laser, my approach is to start at where it hurts, move all the way to where it hurts at the other end, and move in a kind of a line. So if that's this point of my arm hurts, and then there, I draw a line from there all the way up, because that pathway is congested as far as nerve entrapments. We're going to increase the blood flow as well through that whole area. So our radial nerve sits here. This is the lateral aspect. So we're looking here at the lateral aspect of the elbow. So that radial nerve here in the higher portion, as it comes down, it's going to split up into the interosseous nerve and superficial. And this one, the second one from the top, is a superficial. Deeper, these lower 2 X's are actually indicating beneath these muscles, and it's going to the supinator. This arcade through here is where you get a lot of nerve entrapments for lateral elbow pain, and also radial nerve. Okay, so lateral elbow pain tends to be mostly radial nerve related. When you have a tendinopathy in the region, it hurts at the attachment to the bone. Okay, it can be mid-portion of the common extensor tendon, and that's where you'd apply a lower dose of laser. You get the 30 seconds rather than the higher dose. Some people apply a higher dose, and it's good for pain. It may not be very good for initiating fibroblastic activity. It's very much hard to say which is better, but research has really shown 30 seconds or lower doses are much better. The higher doses, they seem to be hit and miss with research. Okay, anterior elbow, or there is a caveat here in that most elbow pain, whether it's lateral or medial, you should also treat anteriorly. I would generally, as a rule of thumb, treat every tender point of the nerves in the elbow for either lateral or medial. You do all of it, okay? So better protocol would say is just do everything with the laser. You should have enough time, 1 minute to 2 minutes per point, and there's not a lot to treat, you know, so you've got to look at the radial nerve. These points here indicating the superficial component, but also, you know, that behind that brachioradialis muscle there, you've got the supinator. Then you've got here in the pink color, that is actually the musculocutaneous nerve. And that point there is incredibly important. You should be able to find it deep under that brachioradialis, and it really hurts. It really hurts. It's actually often a combination of the radial nerve and musculocutaneous nerve being flicked at the same time. But often I'll treat that for shoulder pain as well. It's quite an effective spot, that area of the elbow through here. I wish I could show you properly. But median nerve. So median nerve is coming down from the medial aspect of the humerus, and it's going to cross underneath the biceps. Now there's 3 points here. One is under the pronator teres, the lower part there, and underneath the biceps tendon there, the insertion. That insertion there is behind, so you'll be able to find that biceps where it's relaxed. There's a nerve behind the biceps tendon there, and up a bit more medial and proximal. Try to find it on yourself. And like I said, go back to your anatomy applications such as complete anatomy. They're very helpful to find nerves. And the only addition here is the ulnar nerve. So coming at the ulnar nerve along the medial posterior aspect of that humerus, you'll see that there's an impingement site proximally, just into that cubital tunnel on the medial aspect of the elbow, and then just distal to that. Okay, so most of you would have felt this sore point here, here, and just a bit lower here. All those sharp points, those are for medial elbow pain. Same rules apply for a tendinopathy there. So common flexor tendon, you would apply a low dose over that attachment, the tendon, if it's tendinopathy. Okay. Hand and wrist, really the same nerves. The difference is that you're going to go for a lot of areas. Generally, I'm just kind of giving you a blanket approach here, but go where it hurts, but you'll see that these points tend to come up. This is the palmar view of the hand. So you can see the median nerve goes into the palm instead of the ulnar nerve. And these are all the pathway and potential entrapment areas of that nerve. You'll often get pain in the median nerve in between here, ulnar nerve, ulnar nerve, ulnar nerve, median nerve, median nerve. Big one though is on the next one. Our radial nerves in here, between the fingers at the distal end, and along this line here. This is the big deal here. The radial nerve sitting here, just underneath the thumb. As you go in between the thumb and the index, this is where a lot of the nerve pain is there, right along that metacarpal. Okay. So laser pointing all through here. I will confirm what this approach is in a moment. So we're going to do scapulothoracic. Now, this is the last one. I'll take questions after this. Scapulothoracic area, this is the posterior view. On the left-hand side, we're taking a lot of the musculature off, so you can see it all the way down to the bone. You have 3 main nerves of concern, right? So the dorsal scapular nerve runs more medial to the spine of to the scapula. And it is that kind of lateral rib pain area, right? That area all the way up to the levator scap pain, levator scap trigger point, which I would say is dorsal scapular nerve more often than not, could be accessory nerve. these are the areas that you would look for, okay? Now, I've also talked about the dorsal rami and the lateral rami, or the medial. These are all part of the dorsal rami, and these are coming out of the vertebrae, out through the foramina, and it goes posterior towards the lamina and to the spinous cap. It's not spinous cap, sorry, spinous process, and then laterally to the rib. So you can see all these points along the rib are potential sites of lasering, and then all the way, you might say you're lasering the facet joints, but you are probably effectively lasering this medial dorsal rami. Okay. And on the lateral view on the side here on the right, you can see the points of concern for the spinal accessory nerve, which is going to innervate the trapezius muscle in the SCM, but in this case, it's trapezius. The dorsal rami and medial and lateral ones are really for that medial spinal pain that kind of goes a little bit out. It feels like rib pain as well at the joint, whereas dorsal scapular nerve is ones that affect more medial scapular area rather than all the way into the spine. And you can follow a line from top to bottom with the high-powered laser, or you just hold one point for 30 seconds to a couple of minutes sometimes, just to reduce the pain in that location. Okay. All right, time to ask some questions. Any other questions? Sorry to rush through that, but you'll have those PowerPoints to refer to. It's the best I could do. Very difficult to explain this over a PowerPoint, but I think that considering all the PowerPoints I've ever watched of laser, this is how they show it. I use a combination of, I'll tell you what I do. The therapies I use are shockwave therapy, laser therapy, joint mobilization, various forms of that, including MWMs, Maitland technique, so many different techniques. Rehab methods, dry needling with electric current, cupping, yes, high-powered laser, all laser forms. I have 2 different lasers in my clinic. I use a lot of therapies. I predominantly use laser and shockwave though. Yep. Any other questions? If you prefer not to type, you can unmute. Would I use low-level laser more than high? Lisa's asking me. The good thing about low-level laser for me is that this would be the benefit over high, right? Is that if I'm trying to improve a 1 point of tenderness, right? At the particular wattage that I use, in particular wavelengths and so on, I find it very useful over scanning 1 point, right? And I know that you can use the high-powered laser over 1 point, particularly at a lower wattage. But that would be like overall, like it doesn't really make much of a difference because you're changing the wattage based on what you're doing. So you bring it down if you want to hold it over 1 point, yeah, to improve that 1 point alone, or you use the scanning method, which is to move it. A little bit similar to how cupping, there's people who use cups and they slide them, whereas some people hold them in one position. It's kind of the same thing in a way. Why would you use one over the other? I personally, that would be how I would differentiate it. If I wanted to affect a bigger area, possibly quicker, I would use the higher power laser. And if I just wanted to affect 1 point, I might choose the lower. But to be honest, it just depends on the machine you're using and what you feel comfortable doing. And I also use the lower level laser more so over the head. But I've traditionally mainly used low level laser. I've been using it probably since 2013. I frequently go to the AMLA conference in Sydney, Australian Medical Laser Association's conference. Most of the discussions there are using low-level laser. Most of the Australian researchers at Sydney Uni are using low-level laser, particularly near-infrared and infrared. But that doesn't mean you don't use the others, just that's where a lot of the Australian research is being done. Yep. Any other questions? You can